Hello, I'm Dr. Nirupa, obstetrician and gynecologist at Akkineni Hospitals. Hope you're safe and well. Today, I'll be sharing some important information. Stay tuned and take notes.
Welcome to today's Explainer. We're diving into a massive topic that affects literally millions of people, yet somehow it remains incredibly misunderstood. Our mission today? To use hard medical facts to completely dismantle the societal normalization of severe period pain. Because let's face it, for way too long, absolute agony has just been brushed off as an expected part of life. We are going to decode dysmenorrhea, which is just the medical term for period pain, and really break down the science of exactly what is happening inside the body.
Just look at this quote. It's just cramps. It's normal. I mean, it sounds so familiar, right? But medically speaking, this is probably the single most harmful phrase in women's health. If you're watching this and you've had your own pain dismissed with these exact words, I really want to validate your experience right now. While mild cramping is physiologically expected, the normalization of moderate to severe pain is a deeply harmful practice. It leads to massive undertreatment and, honestly, it acts like a smokescreen that hides some really serious underlying medical conditions. The sheer scale of this issue is just staggering. We are talking about 50 to 90% of women of reproductive age experiencing period pain. That is a massive, massive majority. And, well, it illustrates exactly why this issue is so widely and dangerously normalized. Think about it. When something happens to almost everyone, society tends to just lump all variations of it into one giant bucket labeled normal. But, as we're going to see, there is a very clear medical line between expected physiological pain and a blaring warning siren from your body.
Section 1, Primary Dysmenorrhea, Expected versus Excessive. Okay, let's get into it. So let's unpack what is actually physiologically expected. Primary dysmenorrhea is absolutely not in your head. It is driven by a very real, very potent chemical mechanism. Specifically, it's caused by an overproduction of chemicals called prostaglandins, primarily PGF2-alpha and PGE2. Now, these are released by the endometrium, which is the lining of the uterus, right as it sheds. These chemicals, they are the true culprits behind the pain. They act as these incredibly powerful triggers for a whole cascade of intense physiological reactions.
It's basically a microscopic battle happening right inside your uterus. Step 1, that shedding lining starts pumping out those excessive prostaglandins. Step 2, these chemicals literally force the uterine muscle into intense contractions and cause vasoconstriction, which means they restrict blood flow to the area. This creates what doctors call ischemic pain. It's the exact same type of agonizing pain you get when a muscle is completely starved of oxygen. And finally, step 3, prostaglandins actually hypersensitize your pain nerves. They make you feel everything so much more acutely. On top of that, these chemicals can escape right into your bloodstream, which perfectly explains all those terrible full-body symptoms like nausea, diarrhea, headaches, and that awful lower back pain.
Now, this chemical process builds into a very predictable timeline. Primary dysmenorrhea is highly structured. It typically begins about 1 to 2 years after someone's first period. Once those cycles actually become ovulatory, the pain usually kicks in just before or exactly at the onset of menstrual flow. It peaks intensely within the first 24 to 48 hours, and crucially, this is key, it resolves by day 2 or 3. This predictable colicky lower abdomen cramping, that provides us with our baseline for what standard non-structural pain actually looks like. Because we know exactly what the chemical cause is, we've got some actionable treatment tactics. First up, NSAIDs, things like ibuprofen or naproxen. These are super effective because they actually inhibit prostaglandin synthesis right at the source. But here's the real trick. They work best when you take them 24 to 48 hours before you even expect the flow to start. Seriously, don't wait for the pain to hit. Stop those chemicals from being made in the first place. Combined hormonal contraceptives are also highly effective because they thin the endometrium, meaning way fewer prostaglandins are produced. And, fun fact, multiple clinical trials show that using localized heat therapy on your lower abdomen is just as effective as taking ibuprofen for reducing that cramping. Oh, and regular aerobic exercise helps too by lowering prostaglandin production and releasing your body's own pain-killing endorphins.
Okay, so this right here marks the critical pivot in our explainer. Primary dysmenorrhea, the stuff we just talked about, has no identifiable structural pathology. The uterus is structurally completely normal. It's just producing way too many chemicals. But secondary dysmenorrhea, that is an entirely different ballgame. This is pain with an identifiable physical structural cause. This is when the pain is no longer just a chemical reaction. It's an alarm bell for a hidden pathology.
Section 2, Secondary Dysmenorrhea, Spotting the Red Flags. Let's look at what to watch out for.
So how do you actually spot the clues that you're dealing with something structural? Well, you need to look for these distinctly different warning signs. Does the severe pain suddenly begin in your mid to late 20s after years of totally pain-free periods? Does the pain progressively worsen over months or years, or maybe it starts well before your period and just keeps getting worse? Other massive red flags include deep dyspareunia, which is pain during intercourse, and dyschezia, meaning pain with bowel movements during your period. Plus, if you're experiencing unusually heavy bleeding, subfertility, or if those NSAIDs that used to work perfectly suddenly just stop helping, listen to me, these are not normal cramps. These are absolutely critical signs of secondary dysmenorrhea.
So what's causing it? Well, here are the primary culprits behind that secondary pain and exactly how specialists diagnose them. The leading cause is endometriosis, which is where tissue similar to the uterine lining grows outside the uterus, causing this progressive inflammatory pain. And to definitively confirm that, you need a diagnostic laparoscopy. Then there's adenomyosis, where those same endometrial glands grow deep into the uterine muscle itself. That one is best spotted using an MRI. We also look for fibroids, which are literal growths that distort the uterine cavity, easily visible on imaging. Past infections can leave scarring too. That's known as pelvic inflammatory disease, or PID. And hey, even a copper IUD can significantly increase your cramping, especially in those first few months.
Section 3. The diagnostic gap. Delaying real treatment.
So what happens when society just continually pushes this myth that all of this pain is a normal part of life? Look at this devastating consequence: 7 to 10 years. Just let that number sink in for a moment. That is the staggering average global diagnostic delay from a person's first symptom of endometriosis to an actual formal diagnosis. 7 to 10 years of progressive inflammatory pain. 7 to 10 years of having your symptoms completely dismissed. This heartbreaking diagnostic gap is directly caused by the widespread normalization of women's pain. When everyone just assumes severe pain is normal, well, nobody bothers to look for the actual disease causing it.
And this brings us to the core takeaway of our explainer today. Progressive worsening pain requires specialist investigation. Period. It requires thorough clinical imaging and definitive evaluation. It absolutely does not warrant continued empirical dismissal. Anyone who presents with these progressive symptoms, especially when they're accompanied by things like painful sex or heavy bleeding, deserves immediate, thorough medical advocacy. You deserve doctors who actually take the time to differentiate between a chemical imbalance and a structural disease.
I want to wrap up by leaving you with this really provocative thought. Think back to that 7 to 10 year diagnostic delay. If we, as a society, collectively stop calling severe period pain normal, how many years of agony could we actually save? How many millions of women could get their lives back so much sooner? It is time to empower ourselves with this knowledge, stop normalizing agony, and start seeking the specialized medical evaluation we actually deserve. Thanks so much for joining me on this explainer, and remember, keep asking the right questions about your health.